impacted. It can affect how quickly and easily children can eat. We think about that for both coordination and for the actual muscle tone used for chewing. When you should think about this for your own family. If meals are taking longer than 20 to 30 minutes, if you're starting to have to make more and more modifications to the textures of the food, right? You used to be able to just give foods as you would give to any other child, and then you were mashing them a little bit, and now you're mashing and moistening, and now fork mash is not good enough, and you need to throw it into a blender for real purees. If food seems to get stuck in the mouth after swallowing, or if you see coughing or choking with solid foods, if you are spending more of your day encouraging your child or loved one to eat than you are doing anything else, we should start thinking about efficiency and how it's impacting. The other big pillar of eating that we think about is swallow safety. So when tone is different in children, swallow function is often affected. We really think about this when kids are choking, coughing, or gagging with eating and drinking. When you come to our clinic, that is a question you will hear every single time. When the quality of somebody's voice changes after they're eating or drinking, or sounding like they need to clear their throat or gulp. If we have frequent respiratory infections without known causes, and this can be really hard in kids because loosely from October until April, we expect kids to get back-to-back respiratory infections. What we're worried about here is either respiratory infections where no one else seems to be sick, or a child who just seems to be sick for much longer than everyone else in the home. We also think a lot about reduced interest in eating or drinking. I'm sorry, can everyone make sure they're on mute?
No. Dr. Jaffe, are the slides supposed to be advancing?
Yes.
Because we're still on the same slide.
Oh no, where are you?
We're still on the very first slide.
All right, that's not great.
Okay, now I'm seeing different slides now.
We're gonna just take it out of the slideshow and we are gonna go forward like this. So reduced interest in eating or drinking or refusal to drink is another really good sign that swallow safety may be impacted. Kids are smart. They want to protect their airways. So if they're aspirating with eating or drinking, oftentimes what they'll do is eat or drink less. The first step for workup here is making sure that a speech therapist who specializes in feeding gets to watch a child eat with consideration of something called a swallow study, which we are about to get to. So some of you, if not many of you, may have heard of a swallow study before. It's a moving X-ray picture taken while a child is swallowing or an adult is swallowing to help assess movement patterns, airway protection, and swallow safety. It helps us decide if we need to modify your child's diet in any way to help make sure that it is both safe and efficient. Usually what we do is take different textures of liquids and foods, mix them with barium, and watch them go down on the X-ray to see whether they're going down the esophagus, the feeding pipe, which is where we want it, or if it's passing and going down the trachea, which is absolutely not where we want it. They'll do foods with different textures and then liquids starting at a thin liquid, normal water, and then thickening it up to sort of a nectar thickness and then a honey thickness, now known as levels 1, 2, and 3. A couple things if you're ever ordered a swallow study that are important to know is that if your child will not eat and drink, it is not going to be a helpful assessment. So make sure that your kiddo goes in hungry to their swallow study. Bring their favorite foods. We can add barium to just about anything. Bring their favorite cups, bring their favorite spoons, bring all of their eating utensils for home, and feel free to bribe, because this is one where participation is really paramount. A quick caveat as we're talking all about feeding, which is that children with leukodystrophies often do not need to and will not follow the same growth curve as other kids. When we're talking about growth, it should always be put into perspective of both disease and goal of care, meaning that if we have got a child who is really having severe discomfort because of trying to force feeds, we can say it's okay to give a little bit less feeds, even if the growth doesn't look as perfect, as long as we're not having consequences of malnutrition. It's really important to talk with your care team about what your guiding light, what your guiding star as a family is, and then how the feeding goes into that goal. It's also important to know what the growth expectations are for a given disease, right? For some diseases, linear growth is expected to be lower than it is for other kids. And if we're looking to try to make sure that somebody hits the 50th percentile, it may not be the right goal for that child. So talking with somebody about what the goals should be and how they fit into your bigger goals of care. It's also important to remember that if height measurements are hard to obtain, you can use height approximators, and that we should be looking at trends, not individual data points. So being at the 50th percentile may seem really wonderful, but if your kiddo used to be at the 90th and we're trending down because they're having more trouble that's disease related, that's important to know. It's not the absolute number that's important, it's the growth trend. So if you have a kid, can you guys see my little pointer?
Yes.
If you have a kid who's been here at the second percentile their entire life and they're growing beautifully along that second percentile, I'm going to tell you that sounds wonderful. If you have a kid who started here and is now crossing lines because they're having trouble, even if they're higher than their peer down here, if they're not following their own line, I'm going to tell you we have to think a little bit more about feeding. So you really want to look at the trends. So if there are feeding problems, what do we do about it? First, it's really, really important to think about the difference between safety concerns like aspiration from efficiency and growth concerns, because what we're going to consider is going to be a little bit different. If swallowing is safe, the first line is almost always calorie boosting. So we think about that two ways. How do we calorie boost typical foods? And then how can we get in even more calories very, very quickly and easily? Calorie boosting foods is all the things that adult doctors tell you not to do. You can add heavy cream. You can put cheese on everything. You could put cream cheese on everything. We will tell you to use whole milk, to sprinkled powdered milk on top of things, to add oil, to add butter, to add avocado, to add hummus, to add peanut butter to everything. Generally, kids like this. For some kids, the easiest and best ways to get in the calories is using a high calorie complete formula.
I don't have your phone number.
Something like Pediasure or Kate Farms, good way to get calories in. This is especially great for kids who are selective eaters who may have a harder time with calorie boosting.
650.
If there are concerns for aspiration, you need an evaluation with a speech therapist to make sure we're helping to maximize safe feeding practices. Once again, this should absolutely be done in the context of a family's goals of care. If eating and drinking is really, really important to your child or to you as a quality of life measure, it's okay to advocate that with your team and saying, I understand there are risks here, but this is important to my child. Even if we know there are risks, we can still help modify those. Things like positioning a kid so that their head is up and in the correct position, altering cups, making it harder for kids to gulp, thinking about modifying a diet to decrease the risk of coughing, choking, gagging, and aspirating. Avoiding choking hazards is usually a really good one. Generally, what I tell people is to modify the diet the same way you would for an 18-month-old. So we cut grapes, we don't give whole pieces of popcorn, we do a lot of meltable solids, and then thinking about thickening. That is not the right choice for everybody with swallow concerns, but it is important to think about what goals are when talking about this with your team. And if these feeding problems are not fully resolved by using the calorie boosting and the maximizing of safe feeding practices, we generally consider a feeding tube. The other thing that we think a lot about as the complex care team is making sure that a child has adequate hydration. Hydration helps prevent both UTIs and constipation, and oftentimes with swallowing dysfunction, hydration is actually harder than getting the solid calories in. Which brings us to when we think about tubes. So feeding tubes are commonly used to help provide adequate nutrition and hydration. They can be used to provide 100% of nutritional needs, and they can be used to help augment for things that we need. Some children continue to eat and drink by mouth while using a feeding tube to supplement their intake, and other kids do not. Medication can also be provided through a feeding tube, and generally what I tell parents is if you have a feeding tube, you do not have to fight about meds. So who should consider a feeding tube? The ideal time to think about a feeding tube is when it is not an emergency. And when I say that, what I mean is if we have already fallen off of our growth curve, if we are already dehydrated, then in my mind, our team has missed our window. We start to think about it when growth has slowed, if there's been a noticeable decrease in oral intake, if a family tells us feeding has become much more difficult, if we can't do hydration, or if there are critical meds that are not being given by mouth because the child is refusing. The reason that we say it is better to do a feeding tube before it's an emergency is 3 big reasons. The first is that surgeries are safer when we are nutritionally doing okay. The second is that if we wait until we have malnutrition, we are then asking a kid to tolerate not only what they would need to grow, but what they would need for catch-up growth. That's much harder. So we try not to start from a deficit. And the last is the stomach, like any other muscle, is sort of, if you use it, it's in good working shape. And if you don't use it, it's like my legs hanging out ready for the summer season to start and get some exercise in again, right? We don't want our stomachs to go from couch to 5K. We want to keep them moving all the time so that we are not dealing with kind of a shrunken down, smaller stomach when we start. Many people ask me, what is a G-tube or a gastrostomy tube? It's a very small tube that gets inserted to the stomach that allows nutrition to be supplied directly into the stomach. There are a few types of G-tubes. They can be done by surgeons or interventional radiologists, but most importantly, once the tube is healed, which takes about 4 to 6 weeks, there should be no functional limitations. Usually what I tell families is you can put into a G-tube anything you can put into a mouth because stomachs are not sterile sites. That means you can swim in the pool, in the ocean. It means if your brother accidentally puts some sand in it, which has happened to at least one of my patients before, we don't worry too much about it. And that generally they're really well tolerated. And that once it's been replaced by your initial provider who placed it, they can be replaced at home or by your local team. The next thing that we talk about that is intimately related to feeding differences is constipation. Children with leukodystrophies are more likely than typically developing peers to have constipation for a number of reasons. Motility differences, hydration differences, differences in how the gut moves, differences in positioning, and differences in sphincter tone. It's important to us for a few reasons. Untreated constipation leads to risk of feeding intolerance, poor oral intake, less acceptance of food, urinary tract infections, and in many cases, most importantly, decreased comfort. We like to have 1 to 2 soft stools every 1 to 2 days. So a Bristol 4 or 5 on the stool chart. If your loved one is in diapers, it should smush, right? It should be flat like a pancake at the end. Ideally, good poops are not causing lots of straining. We have so many ways to help treat constipation. But as a general big guiding principles, if we need to treat, you should continue treating unless something changes, right? For all of the reasons above, we know that kids with leukodystrophies have a harder time with constipation. So if you're started on some medication, unless something changed, it's important to think about why you would stop it, right? Because the underlying things that cause the constipation may still be there. 2 big categories of things that we think about. Some kids need help with softening their stool, the squish. Some kids need help with motility, the push, and many kids need both. Compared to the general population, children with leukodystrophies are much more likely to need rectal stimulation as part of their treatment plan, something like a suppository or an enema, because of that sphincter tone. If all of the other muscles in your child's body are tighter than other people's, it's fair to think that that one may be affected too. This is an important thing to advocate for when talking with GI doctors, who generally are less generous with the rectal therapies. But in this specific population, it's often the most helpful thing we have in our arsenal. The other important thing to mention about treating constipation is it is a self-fulfilling prophecy. The way your body knows that you need to poop is something called a stretch receptor starts stretching out at the bottom of your colon. Once you get constipated, it takes more and more poop to send that stretch signal to the brain to say like, hey, it's time to go. I should be squeezing now. So the more constipation a kid has, the more it will take to get the poop out because you won't have the same stretch. In addition, children, all sorts of developments, are famous for holding their poop if it hurts once. So we want to make it soft enough that it really doesn't hurt so that you don't have holding as part of the equation. In addition to constipation, the other GI complication I think a lot about is reflux and vomiting. These are also more common in children with leukodystrophies than the general population. And there are lots and lots of treatments because there are lots and lots of reasons that this happens. things that we think about are medications to decrease the acid, which will not necessarily make somebody vomit less, but it will make it not hurt. We think about changing feeding strategies. Specifically, our group really likes thinking about blenderized diets as a strategy for helping with reflux management. We think about the simple things like position changes and let gravity help us. If your child has a positioning chair that can help them sit upright and let gravity do some of the work for us right after feeds, that is almost always a good thing to have as part of the treatment plan. And then we think about tone management. When kids get really hypertonic or dystonic, they tend to get themselves in positions that lead to reflux. In reverse, with kids with uncontrolled reflux, it tends to set off both hypertonia and dystonic movements. And so for us, our physiatry team and us work really closely together to try to help those two things work synergistically. We think about constipation treatment because if you think about your gut as a giant pipe, if your pipes get clogged up, where does the water go? It goes up. We always want the path of least resistance to be down through the gut. And then we think about motility agents or gastric accommodation agents to help either move the food along the gut or to help the stomach expand a little more so that they're less likely to reflux. One way to think about this is that everyone has a point at which they will vomit. And what are the factors that we can modify to help someone move a little further from their vomit threshold? Can I help with constipation? Can I help with positioning? Can I help with anything that's going to help move the food along? All of those things will decrease the risk of vomiting. And similar to constipation, we care about this for a number of reasons. We want to make sure that kids are comfortable and want to decrease the risk of aspirating from below. Role of G-tube in feeding and vomiting. There are a couple things that we think about when we are thinking about a gastrostomy tube in the big feeding picture. First is we think about how we can feed. We can change from giving what we call a bolus, so a number of ounces all at once, to trickling a little bit more in more slowly. For kids who have trouble with their stomach physically expanding, that can be a really helpful strategy. We think about venting, which is sort of like letting your G-tube burp. And what's really nice about venting strategies is they're something that we can really help a kid with. So we can do things like hold up a big syringe and help air drain out, which can be really helpful. Like we said before, we think about what type of formula we're using. We use blenderized diets a decent amount. We think about clear formulas. We think about the formula concentration. If a child's major problem is vomiting because of volume, can we use a strong formula and give water back at a different time in the day? And lastly, we think a lot about the role of what's called a J-tube or a jejunal tube, which has a lot of pluses and minuses that are truly probably past the scope of what you guys want to hear from me today. But if anyone wants to talk about that at the end, just let me know. The next thing we think a lot about is pulmonary differences. For children with leukodystrophies, we really try to keep the lungs healthy as a great way to keep kids overall healthy. We do this by avoiding aspiration, right? We try to make sure swallows are safe. We try to make sure secretion, saliva control is happening, and we control reflux. Once again, it's important to have a swallow study or evaluation if your child has frequent respiratory illnesses, as swallowing differences can absolutely be a factor. The other big pulmonary difference we think about is sleep disordered breathing. Children with leukodystrophies are at risk for both obstructive and central sleep apnea, and a sleep study is the right way to find out either of those things. So if you have a child who's snoring really loudly, who is pausing their breathing when they're sleeping, who seems really tired during the day, does not seem well rested, if they are desatting on a pulse ox every time you go into a hospital, asking for a pulmonologist and a sleep study is probably a good move. And then we think about pulmonary clearance plans. So we want to help the body do what the muscles would do otherwise without the effects of the leukodystrophy. We do this with chest physiotherapy, really just sort of manually moving the mucus and breaking it up. We talk about a cough assist device, which adds strength to a child's cough to help them clear things. We think about the shaky vest, which in my experience is the one that kids like to know the best. And then we think a lot about inhalers, right? How can we help optimize airway health so that we avoid long-term damage to lungs and we avoid acute pulmonary issues? So big picture take-home points. If we can optimize feeding, reflux, constipation, and pulmonary health, we can really improve the quality of life for our friends with leukodystrophies. Our goal is always to decrease things that are modifiable, and to try to proactively address problems ahead of time, because an ounce of prevention is almost always worth a pound of cure, and that using a multidisciplinary team approach helps make every kid healthier. Thank you for your attention, and I will unscreen share.